Now we will start with the next masterclass session. I would like to invite upon our respected chairpersons, Dr. Khalid Alwadi and Dr. Dinesh Kadam. Please proceed.
So, Dr. Dinesh Kadam. So, good morning, everybody. We'll start with our first session in the master class. I would like to ask Dr. Amitava Gupta to come on the podium and present about the versatile posterior interosseous flap.
Thank you. Good morning. The posterior interosseous flap is a very versatile flap. It's easily available, does not sacrifice a major artery in the hand, and in my hands it's been fairly reliable, so I really like this flap. This is an index case. This is a 23-year-old man. He presented with a gunshot wound to the dorsum of the left hand. You know, that's pretty common in the United States. There's a large open wound on the dorsum of the hand, bony defects of the second, third, and fourth metacarpals. After debridement, a large uniblock cordiocancellous graft is used to reconstruct the defects of the index, middle, and ring metacarpals, and the graft was fixed with K-wires. The extensor tendons are intact. Now we are faced with a defect of 5 by 6 centimeters. The question is, what are the options for this coverage? Obviously, you can do free flaps and other things, so we'll come back to that. The posterior interosseous artery flap was described by Zancoli and Agrigiani. The branch of the interosseous trunk comes off the ulnar artery, and it runs in the septum between the fifth and the sixth compartment. That's EDM and ECU. It's consistently there. It provides 7 to 14 cutaneous branches on the dorsum of the forearm, and distally, just proximal to the distal radial ulnar joint, it communicates with the anterior interosseous artery and also has a branch which goes to the dorsal carpal artery and a branch to the ulnar head. So injection studies shows that there is a very large supply to the dorsum of the hand, and you can pretty much take most of this skin. You should be able to Doppler it, Doppler the vessel all the way across in between the fifth and the sixth compartments and mark the area. So here are the some injection studies, and you can see the perforators that are going. It's a fasciocutaneous flap, so lots of perforators going from the pedicle all the way to the skin, and multiple perforators. And Dr. Zancoli, I spoke to him, unfortunately passed away recently, and he used to say that if you have one perforator, this flap will work pretty well, and I agree with that. But there are multiple perforators. And as you can see in the bottom picture, the pedicle is going across and it's supplying muscular branches as well as perforating branches to the fascia and to the skin overlying the skin paddle. And again, you know, if you go in detail, there are lots of perforators and linking vessels. Further injection studies that we did showed the communication. This is the communication between the posterior interosseous artery and the anterior interosseous artery, and this is just proximal to the distal radial ulnar joint. Uli Buchler told me that and actually he wrote in his paper that in 5% this was absent. However, if you have a dorsal carpal branch which is consistent, and according to Zeidenberg, you can rely on this dorsal carpal branch to supply arterial feed to this flap. So it doesn't matter if the communication is absent. So here are in a live dissection, in live patient, when we're doing the flap, you can see the perforators very clearly, and they're very nice and robust perforators. The artery itself is about 1.5 to 2 millimeter up to 2 millimeter diameter. So what I do is I start. The most important thing is to mark the position, and I mark it with the elbow flexed forearm slightly pronated, and I mark the distal radial ulnar joint and the lateral epicondyle. That's the line. And then you've already Dopplered where your vessels are between the fifth and the sixth compartment, right? So you go along that line and you take your skin paddle. If the skin paddle is less than 4 centimeters wide, then you can close this primarily. But if it's wider than 4 centimeters, I would recommend skin grafting it and subsequently excising the skin graft, and that gives a nice thin linear scar. So I sit on the ulnar side of the forearm, and then I start distal incision. So I start with the distal incision, and that's the key. You have to start with the distal incision and find the fifth and the sixth compartment tendons. And you can, right over the fifth and the sixth compartment tendons, you can just cut with impunity. There's nothing there. You can buzz the vessels, and you can just cut through right over the tendon sheets. Once you have done that, there's a strip of fascia between the fifth and the sixth compartment, and the posterior interosseous artery is consistently there. So let's look at the dissection. In our labs, we developed this technique of injecting veins and arteries with different colors. So I want to present this a new technique we came up with. So here it is. You can see the posterior interosseous nerve, the fasciocutaneous branches, the perforators coming across. You can see the veins and the arteries in different ways. And then you raise it so that you just buzz the muscular branches, and you raise the flap. Now, if you go more proximally, you come into contact with the posterior interosseous nerve, and you see the posterior interosseous nerve there and the branches of it. But you come distally, and you buzz those vessels. And here, coming further distally, there'll be branches to the ulnar head and a dorsal carpal branch. Normally, I will cauterize those branches and then take down the fascia overlying, because you don't need that. If you want to pedicle that, you don't need those things. So, and there'll be some muscular branches. So once we've found the communication between the posterior interosseous artery and the anterior interosseous artery, and here we're going looking for it, and that's the communication. That vessel goes and communicates with the anterior interosseous artery. So in reality, this is an anterior interosseous artery flap, because it's coming, the vascular supply is coming from the anterior interosseous artery. Then I'll divide this fascia, and once you divide the fascia, you get a little bit better length to mobilize and move your flap. Now you can decide whether you want to tunnel it or you want to just make an incision and take your flap overlying that. So that is the communication going to the anterior interosseous artery. Here it is. So now you can see that much better. So and you can go further into the forearm that way. And this will allow you to go to the first web space, heads of the metacarpals, proximal phalanges, web spaces, dorsal aspect of the thumb, wherever. Now, one of the things is that if you go further proximally, so that you can go distally in the hand, if you go further proximally, you come into contact with the posterior interosseous nerve. So I try to keep my ambition with this flap in the middle of the forearm, so the posterior interosseous nerve's branches are not disturbed. Sometimes there'll be a perforator running under the branch to the ECU, and then you have to decide what you want to do with that. If you've got another perforator which is further distally, that's fine. You can sacrifice that perforator. So distal to proximal to the DRG, there are 3 branches. One is the main communication to the anterior interosseous artery, branch to the ulnar head, and branch to the dorsal carpal. I think there's a robust communication to the anterior interosseous artery, and we can ligate the other 2 branches, but carefully develop a plane between the PI pedicle and the overlying fascial strip. Make sure that there's no kink in the pedicle as you transpose it, because you're reversing it. If the width is less than 4 centimeters, the donor site can be primarily closed. And here again are the injection specimens showing the perforators. So what did we do our index case? It was we did the grafting, and we did the posterior interosseous artery flap, reversed it, and closed that with skin graft. So large posterior interosseous fasciocutaneous flap 6x6 was used to cover the defect. Although there was a lot of swelling, we were able to Doppler the PI and the perforators, and the donor site was covered with split thickness skin graft and healed well. The flap and then bone heal, and you can see that you can immediately mobilize and you get good results. So this is the position of the forearm in the cadaver. This is where you could raise that from. Doppler and perforators and mark them, as I mentioned. Draw a line from the lateral epicondyle to the distal radianular joint with the elbow flexed to 90 degrees and the forearm pronated. And the skin paddle is marked along this line. You sit on the ulnar side of the forearm, you'll be able to dissect the pedicle better from this side. It's much easier to get lost sitting on the radial side. Lightly exsanguinate the limb prior to inflating the tourniquet. This maneuver will make the pedicle and the blood vessels more prominent. Start the incision distally. I cannot emphasize this more. People get lost starting more proximally. Find the EDM and ECU and consistently take it from me. It's in between that septum. That perforate is in that septum. Pedicle will always be there. And this is, we've already shown you that. That's perforated in between that, in that septum, and supplying perforating branches to the. Now cut the fascia along the tendons of the ECU and ADM, keeping the septa. Dissect posteriorly to the skin paddle, elevate the fascia. You can suture this fascia to the skin paddle if you like. Dissect anteriorly on the skin paddle, taking the fascia beyond the margin of the skin paddle. From the anterior side now, the fascia is more visible. The perforators are better seen. And the flap can survive on one perforator, as I mentioned before. Follow the pedicle proximally. It may be necessary to dissect the vascular pedicle away from the posterior interosseous nerve as you go further proximally. And we've gone through this video anyway. The main pedicle then more proximally dives deeper and goes proximally. Fortunately, this happens after the last good perforator. The pedicle can be ligated at this point. Make sure the proximal pedicle is double ligated. Occasionally, a PIN branch to the ECU will cross the pedicle. If there is a good perforator distally, the pedicle can be ligated distal to the ECU branch. If the good perforator is proximal to the ECU branch, then you have to decide whether you cut the nerve to the ECU and re-anastomose it. I wouldn't recommend doing it, or you can raise the flap, or you can abandon the flap at that point. If the skin paddle in the middle, keep the skin paddle in the middle of the forearm, especially when you're starting off. Distally, there is no communication to the eye. You can rely on the dorsal carpal arch branch. Flap can be harvested as a free flap, and we've done that. And you get the proximal pedicle is fairly big to do a free flap. It's not a super microsurgery. And superficial vein, you can use this extra superficial vein if you're concerned about venous drain, especially when you're doing in injured limbs. A good vascularity of releasing the tourniquet. If the vascularity comes back right away as you release the tourniquet, it'll do very well, and it'll stay well. I haven't touched wood. I haven't been able to kill any of these flaps. So it's, as I said, you can easily get lost. You position the paddle in the middle of the forearm, and sometimes venous drainage can be a problem. So here are some case examples. This lady had a tumor, cancer in the skin going deep, and this was excised, and a complete excision all the way. The radial sensory branches were excised. Some of the extensor tendons were excised. So we chose to cover this with a posterior interosseous flap and then do some tendon transfers to cover the defect. So here are the branches and the perforators. This is raising the flap, and here's the cosmetic results of this. The cosmetic results were fairly good because we were able to excise the skin graft. We had to put a skin graft and excise it later on. Trauma, saw injury to the dorsum after debridement, covered right away with a posterior interosseous artery flap. Infection, patient had loss of skin over this area, and after a vac was taken down, we took a 6x4 flap and covered that. This is this little girl, 10-year-old, was sitting in her apartment, and there were some people shooting outside, and she got shot. She was just sitting playing in her apartment, and this is her hand. So so we did a posterior interosseous artery flap after reconstruction, and here's her end result of that. This patient had multiple surgeries, so we basically, even despite multiple surgeries and a scarred forearm, we were able to raise this flap. So you can use this and go through the interosseous membrane to cover volar defects. This is a burn injury. We debrided the burn injury and used the posterior interosseous flap, go through the interosseous membrane and covered on the volar surface. You can use it antegrade. So you can raise the flap distally and put it to cover the elbow. And I've used it extensively to cover the elbow, and we wrote up a paper in PRNS. And this patient had 10 commandments tattooed on his forearm. So I told him I'll take 3 commandments and put it in his elbow, and I did. I've done it in APERT, reconstruction of first web in APERT in children. Done it for complex hand wounds where we've done it as a free flap. So it's a versatile flap. It's reliable and very useful. Anatomy is fairly consistent, and no major artery is sacrificed. Donor defect is very acceptable, and the flap can be modified in various ways. So it's as I mentioned, no major artery sacrifice. Donor site is very manageable, and it can be modified in many ways. Thank you very much.
Thank you. Thank you very much, Dr. Amit. Very well illustrated. Any question to Dr. Amit? I have a question, sir.
Yes.
Yeah.
Have you ever considered doing the venous anastomosis to avoid any future venous congestion?
Yeah, as I said, you can take a superficial vein, and then if it's a scarred bed and you're doing through a scarred bed, I have done that. So take a superficial vein and do additional venous anastomosis. Yes.
Any further question? So what would be the proximal limit of the flap proximally? What are the borders?
Right. Proximally, you can go proximal forearm. So just about 3 centimeters distal to the lateral epicondyle, you can go up to that level. But as you go further proximally, you come into direct contact with the posterior interosseous nerve, so branches of it. So I would prefer to keep it in the middle of the forearm.
What's the largest flap you could harvest? I'm sorry.
Largest flap, yeah, you can harvest a fairly good flap up in about 8 by 7, 6 or 7, large flap.
So when you are going into the proximal third territory, would you like to delay the flap? Do you want to delay the flap, or you straight away?
I've never done that. I've never done the delaying. I just do it straight over. All right. Thank you very much.
Thank you very much, Dr. Amit.
May I call upon Dr. Caroline? Yeah. She'll be, this is the second master class. She'll be speaking on nerve transfers versus tendon transfers in tetraplegic hand.
Good morning. Thank you for this opportunity to present. And this is quite a controversial subject. Let's just remember what is a nerve transfer. It's the coaptation of an expandable donor nerve, or sometimes sensory nerve, to the appropriate motor or sensory recipient nerve, whose function is to be restored. The history of nerve transfer gets back to many years. Wang was probably the first one to describe it in 1997, followed by many others. It's been used in peripheral nerve surgery, and it's been used extensively in brachial plexus surgery for elbow-flexion palsy, and we all know about the Oberlin transfer or fascicles of the ulnar nerve to the biceps, and then the double transfer, and then several others. The nerve transfers in tetraplegia follow the general principles of nerve transfers. The donor nerve should be purely motor. It should have redundant innervation, so there is no functional loss. It's better if it has high motor actions density, and the size should be able to match pretty much with the recipient nerve. The donor nerve now should be accessible with direct suture. Grafting is not a satisfactory option, and the suture should be done as close as possible to the recipient muscle. And most importantly for tetraplegia, the recipient muscle should not be denervated, and in many cases we're going to have to operate early because of that requirement. So now on to nerve transfer and tetraplegia. In 2001, we wrote a book with a dear friend, Rod Hans, and there was a request to publish a second edition of the book, and that was done 22 years later. What has changed in between? One chapter, the nerve transfer chapter. The rest has remained pretty much the same. But the novelty, the only novelty in 20 years of time was concerning nerve transfers. So what about nerve transfers in tetraplegia? Well, the very first one to have published the case was a French surgeon. And he did musculocutaneous to median nerve. He said the result was satisfactory, and this went into oblivion. And then Bertelli was the second one to speak about that, using the branch of the teres minor to the triceps, and then several others. McKinnon, the same year, started to publish on that, but the one who did extensive work and publication on nerve transfer is Van Zyl. So the principles here are a little different, and this is a very important part of nerve transfers in tetraplegia. If we consider the lesions, the medullary lesion, what we call the supralesional segment above the lesion, the muscles are intact, and the nerves are potential donors. Now, if we consider the lesion itself, which we call the lesional segment with lower motor neuron denervation, at this specific level, the muscles are denervated. There is early fibrosis, there is motor plate degenerescence. So if we want to be able to restore function in muscles innervated by nerves in that zone, we need to do it early on, before 6 to 9 months after the trauma. And now the infralesional segment, we have what we call an upper motor neuron palsy. And here the muscles are paralyzed indeed, but they are not denervated thanks to the arc reflex. And so there is still some muscle trophicity, and these can be restored late. And failing to understand that part, we can have some unsatisfactory results at the lower motor neuron level. So how do we analyze this? Well, we do not want, as I mentioned, to transfer a nerve to a chronically denervated muscle. So the preoperative assessment is going to try and evaluate that lower motor neuron denervation and its extent. And this is performed through clinical examination at the level of the lower motor neuron segment. There is no arc reflex, there is no spasticity. This is a flaccid tetraplegia, whereas lower down you have arc reflex and you have some degree of spasticity. It's sometimes quite difficult, especially if the lower motor neuron area is small, and then EMG studies are extremely helpful. And I would recommend to do EMG studies every time you think of doing a nerve transfer in a tetraplegic patient. Intraoperatively, we need nerve stimulation, and this would be ideally with bipolar stimulation and low frequency, and we need to test those muscles prior to doing the nerve transfer. Evoked potentials, that would be ideal, as they're not always available. So let's remember about the classification of tetraplegic palsy according to the level of the injury. So in the higher levels, this is classified in the international classification as 1 and 2 level. Those patients need elbow extension, wrist extension, finger flexion, and intrinsex. If we go on to the next level, that's 3 and 4, they do sometimes require elbow extension, sometimes not, but they do require finger extension, finger flexion, and intrinsex. The 6 and 7 level, less frequent. They already have wrist extension, and they need finger extension, finger flexion, and intrinsex. And on to the rare IC8 of the classification, where all they need is finger flexion and intrinsex. And so, obviously, according to the level of the tetraplegia, the needs are going to be different, and the transfers that we can do are going to be different. So Kane in 2015, that's again with Van Zyl group, did a literature review of all the cases that were performed. And you see here in 2015, we're already doing a number of transfer of different nerves to the triceps muscle. And most of all, and this was a major part of this review, transfer of the supinator to the PIN, and we'll go back to that. Now, for pinch and grasp, there have been attempts with distal part of ECRB and with brachialis nerve. And for wrist extension, the brachialis nerve, or one of the brachialis nerves, has been transferred to the ECRL. So how about elbow extension? Mostly teres minor to triceps. This has become pretty standard. Again, Bertelli was the first one to describe it. And Van Zyl published her cases in 2019 on 16 patients. She uses a branch of the teres minor and sometimes adds one posterior branch of the axillary nerve to it to make it larger. And the results have been pretty good, but the strength of the triceps never exceeded a 3. And this is not as strong as tendon transfers to the triceps, and we should remember that. Now, finger extension. This was the first specific nerve transfer that was reported for tetraplegic patients. First case by Bertelli again in 2010, and this has been coined SPIN or S-PIN, supinator to posterior interosseous nerve. This is an ideal transfer. The supinator muscle is always strong very early on in IC2, 1 and 2 levels of tetraplegia. If we harvest this nerve, it is compensated for by the biceps, which is a supinator. There is no other possible transfer in tetraplegia for finger extensors, and usually we deal with that as taught by Zancoli with a tenodesis, which is never as good as a transfer, and it does in the end save an operative session. There have been several cases reported. There have been small series, but again, it's Van Zyl in 2021 who published a very large series of 44 cases. The surgery is usually pretty straightforward, although there are some variation in the motor nerve anatomy. And you can see here on this little scheme, it's quite easy. As soon as the 2 branches of the supinator have been identified, and we can see them right here, then the PIN will be cut right after those 2 branches, and then the 2 branches are nicely brought back to the posterior interosseous nerve, and you can see the two branches to the posterior interosseous nerve. This can be done through small incision. It's quite straightforward. My recommendation would be to first go for the superficial branch of the radial nerve, and then work your way back into the supinator branches. And again, nerve stimulation is mandatory here. Post-op rehabilitation needs to be well understood. For the first part of the rehabilitation, we're going to try and find the donor, the recipient movement, together with the supination. And this is key to the early times. And then when it starts being active, we can start doing the, and you can see here we're not blocking supination, and in the next movement we are going to be blocking supination, and you see that it works much better, and that's how you make it stronger. Results from Van Zyl series, 44 cases in 26 patients, follow-up 24 months, and the results were quite satisfactory except for 2 failures where the muscle was very weak. There has been temporary weakness in the wrist extensors, but all recovered within 9 months. So this transfer provides better movement than with passive tenodesis. We don't need full strength for the finger extensor, so an M3 plus is okay. It does restore finger and thumb extension, and it will also balance radial deviation of the wrist, which is often present. In case of failure, we can always go to extensor tenodesis as instructed by Zancoli. There's one problem, however, with this technique is in high levels where the triceps need to be restored. So we can restore the triceps with the nerve transfer from the teres minor, and this can fail, and we'll see to that in a little while. So if this fails, then we're going to need to use the biceps for transfer as a tendon to the triceps. So we cannot do a spin. So that's a problem, because we have to wait probably until we have done the nerve transfer to the triceps, see the result, and then use the spin. So that makes the delay very long. And we should always think of this before embarking on those surgeries. Do not burn bridges. You should always have a secondary solution. Now, faster finger flexion. The experience with ECRB has been better in the result than with the brachialis. The problem with using an ECRB branch is we could weaken wrist extension, and this is always a problem. We do not want to weaken wrist extension in tetraplegic patients. This is a result from Van Zyl of spin and branch of ECRB to AIN. Very nice looking hand, maybe not very strong. So what are the pros and cons of these nerve transfers as opposed to tendon transfers? Well, there are many advantages. We have more source of motors, especially proximal motors that we cannot use as tendon transfers. We don't have a functional loss if we use a branch of a nerve. We all know that an axon can multiply by 5 at least the number of fibers. We re-innervate the prime mover, which is always better than a tendon transfer, and we can, in some cases, use a single nerve for several functions. Small incisions, less invasive. We don't have problems with setting the tension, no long-term immobilization, straightforward rehabilitation. But there are some disadvantages. The strength is a major problem. In all the studies, whether case report or case series, there is not enough strength as compared to the tendon transfers. And second disadvantage is the delayed results. This is the study by Van Zyl that shows us that nerve transfer give a 2.9 strength of grasp, whereas tendon transfer give 3.9 grasp. So this is 1 point more. Same for the key pinch. And we must remember also that some of these transfers do fail. And looking at the literature against Van Zyl work, there is a 12.5 failure, which is much more than what we used to with tendon transfers. Timing of surgery, I won't go into the details, but that can be a problem. We need, again, to think twice, not burn bridges, and make a plan for failure. What are we going to do if this fails? Probably the future lies in one of Van Zyl's publication, 2019, in combination of nerve transfers and tendon transfers. So this is a growing field. We're still trying, we're still experiencing different things, and I think this is very exciting for the future. So as a summary, don't remember to study the lower motor nerve lesion area. Better results in lower spine injuries, in lower levels in the classification, better results with distal donors, and better results for finger extension rather than flexion. Thank you.
Any questions from the Dr. Yes.
Caroline, wonderful. It's more about timing. Is that when would you say the balance between waiting a bit longer when the recovery is, you see there's a flicker, whether it's improving, or in those cases, what is your plan normally?
Well, this is a question that applies to all surgeries in tetraplegia, whether nerve transfer or tendon transfer. Usually by 6 months period, we are pretty confident on the level of the tetraplegia. We can ascertain pretty much, where this is going to go and where it's not going to go, what's going to recover and what's not going to recover. And I'm talking here about complete tetraplegia. Incomplete is a totally different field. And so by 6 months, you're pretty confident where it's going to go. If this is a case where it's logical to do to restore finger extension, then we would do that right away with a spin. And this is the only case when we operate that early. So the spin is performed as soon as 6 months. At 6 months, there is a psychological drawback. Patients very often are not ready to hear about restoration surgery. They think they're going to walk, they think they're going to use their hands. But the spin, you can sell it, easily, because you tell them, small incision, you're not going to lose anything, and we're gaining time if, in the end, you decide to have a restoration of the upper limb. So that's the way we usually do it. Then if we do not do spins and we do other things, we would probably wait a little longer, and part of it is for psychological reasons, because we want to have the patient cooperation, and it takes time.
And what about incomplete? They've got a flicker, and that's where a lot of difficulties are.
Yeah, incomplete tetraplegia is, this is probably by far the most difficult cases we have to deal with. Then we would wait. And then we have spasticity, it's a mix of spasticity, of flaccid palsy, and you really have to wait to understand the picture. We would use Botox before deciding on any surgery and so forth.
Thank you.
If the presentation is late, especially in the upper segment, would you consider some tendon transfers?
I'm sorry,
if the presentation is late, if the patients are coming late.
Oh, late. Well, remember that if you're dealing with upper motor neuron lesion, there is still some activity in the muscles. There is no atrophy. So If you only want to restore function in the upper motor neuron muscles, then you can do it very late. Absolutely. Absolutely. And Van Zyl has published, I don't know if she's published, but she's been communicating about results of late transfer after 2 or 3 years. Thank you.
Thank you so much for your presentation.
So I would like to call our third presenter for today, Dr. Alastair Graham. He will be talking about musician hand and dystonia.
Thank you very much. Thank you for the organising committee. Thank you very much for my amazing colleague Ramesh Chenagiri, who helped coordinate this and get me the invitation. The best colleague you could have, really. I'm going to talk about focal dystonia. I'm going to talk more about this than about musicians, I think, for this audience. Just out of interest, how many people in this audience have diagnosed focal dystonia in their hand clinics? So about 4. This is not a talk about surgery. These are non-operative, and they're not really our field. But this is a very important part of the jigsaw puzzle when it comes to thinking about hand function. So if you don't understand dystonia, then you're not really going to understand cerebral palsy, you're not going to understand motor function in general. And it's highly occupational as well, this. This is the valley where my hospital is based, a very beautiful valley, 200 years ago, the Wye Valley, where High Wycombe is. And then they built this very beautiful hospital in 1965, and it remains extremely beautiful in a way that only the British can achieve in a beautiful valley. This is the last time I was in South India as a medical student in 1990, and this is the last time I gave a lecture in India in 1990. I was talking about HIV in Tamil Nadu, and the audience confidently said, this will never come to India, but hopefully today this is something that does affect people in Bangalore, and it does. I was looking online, and there's some neurosurgery in Bangalore at the moment. There's a group doing dystonia surgery. So here's a case. He's a 58-year-old professional, and he develops, just out of the blue, clumsiness when he tries to write. And it started a while back. It only affects his handwriting. And he's otherwise entirely well. And when you examine him, it's completely normal. There's nothing wrong with his hand at all. But you give him a pen, and it does this within 10 seconds. You get this kind of white knuckle contraction of the radial 3 digits. And 3 years later, he's tried various things, and they haven't worked. There's no change. And he starts writing with the left hand. A very similar case, a teacher, school teacher, and she has clumsiness when writing, and she's seen a lot of specialists, and they examine her, there's nothing wrong with her. And this is her comments. And it's just as if the index finger doesn't belong to her when she tries to write. And she's told that one of the nerves has stopped working. Then another doctor explores the radial nerve at the elbow, and she develops a radial nerve palsy, which recovers, and there's no change. And she can do everything else. It's not a major problem for her, but it's curious. A standard definition of dystonia, a very odd situation. I think this doesn't emphasize what to a surgeon sounds quite bizarre. It sounds bizarre and it looks bizarre, and it might make you question the sanity of your patient. And it's been known about for a long time. Charles Bell, who is the father of study of the hand, back in his treatise in the early 19th century. Solly, who was at St. Thomas's, neurologist, talked about writer's cramp. So writer's cramp, true writer's cramp, that's not just getting tired when you write too much. It's a paralysis that only affects the ability to write. So the typical presentation is like my first 2 cases. Sometimes there's a tremor, sometimes they get some tingling as well. And there's a slight association with carpal tunnel and ulnar nerve in a secondary way. And it can look like that. This is a guitarist. This is torticollis, which we don't see so much, but that's the most common type of focal dystonia. And it can affect the leg too. And it's rare, 1 in 10,000 maximum. But the curious thing is it's 20 times more common in professional musicians. So there's a lot of people interested in that. It has various risk factors. This is the Boston group. They saw, so there are plenty of musicians' clinics and performing arts clinics around the world. So this group described 2,600 cases of focal dystonia in musicians over that period. So a vast experience. And they said what we see mostly when we do music clinics is that there's normally a trigger, which is both stressful and a period of intense practicing, sort of 10 hours a day. And the treatment, as I said, is non-operative. That's the main message. And it's quite an easy diagnosis to make. So the interesting questions are, why is it missed so much? It is missed. What causes it? And then treatment. I'm not going to cover treatment today. I mean, it's a vast, there are whole week conferences devoted to focal dystonia. So the way our minds work, you know, if you get a GP letter, you probably can't read that, saying you've got a rheumatoid patient who can't flex the IPJ of the thumb, you think, you know the diagnosis within milliseconds, and within a few more milliseconds you've got a kind of treatment plan mapped out in your head. But if you get someone with sort of vague this and that and their mind goes blank, you know within milliseconds it's going to be a difficult one. You're not going to come up with a diagnosis in the first 20 minutes or even the first 20 days. So what do we do? So this is more about the philosophy of making a diagnosis when you're a bit perplexed. So diagnostic uncertainty. And it's been studied. It's been studied a lot. People have studied us like rats in a lab. One approach I have when I'm teaching about uncertainty is to switch it around, saying forget about you, just think about the patient. What could be wrong with a patient? And this is pretty exhaustive actually. So that whatever is wrong with your patient will fall into one of these categories. It could be something occult that your job is to put on your Sherlock Holmes hat and work out what it is with more scans. And you know, it's going to be one of those kind of rarer things you pull out of the bag every now and then. In the UK, TB as a cause of monoarthritis is often missed for month after month. It could be a diagnosis that's there, and you're supposed to pick it up, and there are chapters in books about it, but it's in a different specialty. And the reason your carpal tunnel and on the nerves didn't work is because there's something else higher up that you've missed. It could be something brand new you can put your name to and become famous. It could be something that is like atypical carpal tunnel, and you have to squeeze it in, shoehorn it in, I call, to the wrong diagnostic category. It's the high-risk strategy, this, when you're cramming something into a group that it doesn't really fit into. And then for completeness, there's paramedical things like fibromyalgia, whatever that is. And there's an overlap there with somatizers, so those are people who just get anxiety about common symptoms. And then true psychiatric and psychopathic disorders. So focal dystonia is this one. And your job is to redirect them to a neurologist quite quickly. So here's a third case. And you know, the GP has said it doesn't quite feel right for carpal tunnel. So he's a 43-year-old man, clumsy in his left hand when he writes, and it's more severe than the other two cases. It's spread to typing, and then he starts writing with his non-dominant hand. He's got a history of anxiety. His examination, I won't show this, is completely normal. There's nothing wrong with his hand at all. But if you give him a pen and he starts writing, then you can, if you watch his middle and index fingers, they sort of do funny things. And if we just flick through this a little bit, upside down, he's just writing "the cat sat on the mat." And he's sort of, you know, he's having to reset his hand all the time. And this is writing as fast as he can. So he's having to change his technique now. He's squeezing between thumb and ring finger. And we'll see his typing in a second. It's slow. Yeah, here's typing. So cerebellar control is good. He can do all that kind of twiddling in the air. But now I've asked him to type his name, and his left hand just goes bizarre straight away. And it makes you think maybe he's having you on. And beyond that, I've asked him to do up a button, hold a fork. He can't do that either. So clinical assessment of these difficult patients when you're dealing with uncertainty, I think an important principle is that the most senior person in the department should see them quite quickly. You don't want fellows sending them off for endless tests for months and months. This is a diagnosis that's based entirely on history and examination. You have to recognize the description of a movement control disorder. This is an occupational problem, so we become occupational physicians in that situation. And you have to ask a little bit more about how it's going to affect their livelihood. And you have to ask the patient what happened. So give them a pen. If they play the piano, you've got to give them a piano as well. Anything you need in terms of props has to be available. And the differential diagnosis, if they've got fixed posturing, is a bit broader. There's psychogenic posturing, there's CRPS, and there's various clenched fists that are interesting, particularly in the elderly. Moving to the etiology, first of all, this is the old-fashioned model of how we move, how we do things, how I'm operating my mouse hand at the moment. So we have an idea. It goes to the frontal part of our brain. Then there are signals sent to the motor cortex, down to the spinal cord, to muscles, they affect a movement, and there's a sort of feedback set of... It's not like this, though. But this is what was taught in the 1970s and 80s. And the motor cortex is sort of helped in its journey of controlling movement by various subcortical structures. This is a piece of music, and if you show that to a pianist, a professional pianist, they will play it immediately, note perfectly, without thinking of it at all. And you might think that you might start there with a little finger playing an F, first note, and there's a little cell that just brings down the little finger. And so looking through that, there's a sort of motor homunculus, and you stimulate a cell there, and it brings the little finger down. But that's not how the brain works at all. If you stimulate a cell there in a monkey, then you will get a complex movement. You don't get a single muscle firing. For instance, this cell produces hand to mouth from anywhere in space. So from top left or from bottom right, different muscles are going to be activated, and of course there's going to be balancing writing reflexes at the same time. So probably this is a 19th century text looking at this piece of music, and this is monitoring horizontal wrist motion during this as a pre-programmed thing. But probably for this particular musical passage, a cell will be responsible for 12 groups of note at a time, because the 12 groups of note are going up, and then 12 down, and then 12 up again, and they're playing in a fixed pattern that this pianist would have done before. All of those patterns would have been part of their training. Charles Sherrington, the famous neurophysiologist, said intelligence is the ability to inhibit fixed actions. And this is very important in cognitive behavioral science. And the control of movement is done by the basal ganglia, this complicated set of subcortical structures. And essentially, they have input from absolutely everywhere in the neurological system. They process things with little bits like the substantia nigra, the little bits involved in Parkinson's. And there's an output that is singular to the motor cortex. And so it's a little bit like a funnel, or an upside-down funnel. And there's lots of inputs, and then there's a single output. And the output is inhibitory. So you have these sort of loops of processing that go round and round and reverberate, and they will control any activity. So a good example for us would be operating with a scalpel on skin. And you know, you've got a registrar who just cuts straight through the skin, just cuts straight through the radial nerve onto bone, and then you've got a cautious SHO who spends 20 seconds getting through the epidermis, and you're kind of, you know, losing the will to live. But that ability that we have of just cutting it just right according to what we see, so the context of our motor skill is given to us by the basal ganglia. And they essentially inhibit all the things that we shouldn't be doing and leave you with the one that is correct. And the output is GABA, which is an inhibitory. So the traditional theory was that there was a motor processing error in the basal ganglia, and particularly dopamine and genetics of dopamine and then something very complicated that we have to do, like music, and then an emotional element, because the emotional senses, the amygdala and things are feeding into the basal ganglia too. And that produces system overload. And then from a robotics point of view, movement grinds to a halt. That's when robots fail, they fail in various ways, but one is a hyperactive grinding to a halt. Nowadays, it's felt to be more complicated than that. I won't go over that, partly because I don't understand it. Final little thing is we should remember that the human hand that we operate on really hasn't changed much. The third one up, afarensis from the Leakeys and things in Africa, their hands look almost the same as ours. You know, a few subtle changes to the hook of the hamulus, of the unculus, the hamate. But what's changed is our brain has increased by a factor of 10, and we've learned to do things like play the piano, and our brain is the thing that fails in dystonia, not the hand. The hand is just a puppet, and the puppeteer is the thing that fails. So in summary, it's an easy diagnosis, but only if you've seen it and heard of it, which is why I'm here. Except in musicians, it's pretty rare. You see it in golfers as well, so putting dystonia is well known. Probably affects 20% of professional golfers. Avoid shoehorning into the wrong category and sort of doing nerve releases. Pathophysiology is an area of intense research. Don't be tempted to operate. Thank you very much.
Thank you very much. So, any question to Dr. Graham?
Do these patients only complain of clumsiness or pain and cramps also? Only
Yeah, pain traditionally isn't part of this, but the spasm itself gives them aching. And they're often described as if their hand doesn't belong to them. Sometimes musicians will punish their hand as well. So there's quite a psychological element to this.
Is it self-limiting, or it once comes it will remain forever?
It has a very poor prognosis, sadly.
Does it ever become better with time? Have you seen some patients that it is there for some time and then it becomes better?
That's quite rare. I haven't talked about treatment, but there are ways of bypassing it, essentially. So by modifying the way that you do things, sometimes you can avoid it. I mean, the human spirit, we know that from amputees and things, you know, the human spirit has evolved ways of just bypassing problems that we have, whether you have tetraplegia or whether you have an amputated hand. And this is no different than that. You just have to do everything in a different way.
Yeah, I know you are not talking about treatment, but very, very curious to know what you did for that first patient.
Well, I didn't do anything because I'm a surgeon, and you can't operate on these people.
Non-operative, what treatment did you give?
I have an interest in musicians, so quite a lot of the empathy and understanding. I mean, our job as doctors primarily is to tell people what's going on, explain it, to try and predict the future, which is very, very difficult. But if we know a little bit about what the future might hold, we need to be honest about that. Like if you've got a 20-year-old, you say maybe you need to switch to a different musical instrument, perhaps, because it's not going to work out. Just as a 16-year-old cricketer or something who's getting repetitive problems, you say, look, it's just not going to happen. You're not going to play internationally. So we do have a responsibility in that because no one else does. We understand occupational hands better than anyone else in the world. And therefore, I think our judgment in how hand disorders affect occupation is really valuable. So I think predicting the future. But in terms of treatment, then it's a little bit different. Treatment essentially is modifying. So there's a physiotherapy school, starting with some sort of, there are various groups. Someone called Nancy Bill, who worked in San Francisco with Mike Merznick. There was a guy called Philippe Chamain in Paris, who worked with Raoul Tubiana, and they worked, and they often you had to learn the musical instrument all over again, even if you were already good. But the ultimate thing is neurosurgery. You can have deep brain stimulation, and you can have thalamotomies, you can have pallidal stimulations to stimulate the basal ganglia to produce more inhibition so you don't get so there's quite a lot out there.
Do they get better after all that treatment? What can we tell them that
there are case reports of people having neurosurgery who are cured. Yeah.
Thank you.
Yeah.
I remember one of the case in which I was treating for focal dystonia, and somehow it came to my mind that something is going wrong. So it turned out to be the Wattenberg syndrome. So we did the xylocan local xylocaine infiltration around the superficial radial nerve, and his writing immediately improved. So ultimately we did the superficial radial nerve release from the brachioradialis, and he improved. So this lateral thinking should also be there while treating them.
It's interesting, isn't it? And whether that was a true dystonia or whether that's some sort of muscle spasm that was more peripherally driven, I don't know. Obviously, Wartenberg syndrome has nothing to do with a motor nerve. It's purely sensory at that level. But I suppose there will be, that it's a little bit like CRPS. I don't know what it's like around the world.
Maybe, but
we have people I know in Europe, so Paco Peñal and from Carlos Heras-Ballou, who believe that CRPS is all cutaneous nerve driven. So
Correct.
it's cutaneous normal. Other people say it's absolute rubbish. So I think there is an ongoing debate about that. But most dystonia is not caused by peripheral injury.
correct. But he was only presenting with the
Yeah, no, it's
not
very
able to write.
It's very interesting, and I guess local anaesthetic injections are worth trying if you're that confident.
Convincing to what he said. I think a lot of peripheral nerve compressive neuropathy also present with these kind of atypical features.
Yeah, well,
It could
there's
be
about 25% of people with hand dystonia have an element of even neurophysiologically proven nerve compression, but it's all felt to be secondary. And if you release the nerves, peripheral nerves, you might improve their tingling, but you don't affect the dystonia. But it is an important, and we don't quite know why. It could be co-contraction, because there's a lot of co-contraction here, but co-contraction itself shouldn't really cause nerve compression that much, I don't think.
Any role of intertendinous connections?
Like limbo Comstock. I don't think so. I mean, it's a separate interest in so the musician's hand is interesting, and there are well-known people like Robert Schumann who used to stretch their fingers out because they had anomalous connections that sort of didn't help them, particularly differential little and ring finger, which is sometimes you have to move very, very fast independently, and obviously not everyone is set up to do that, and people have sort of ruptured various parts of their extensor anatomy particularly, and the junctura, to try and achieve that. But I don't think it's really a driving force. That's probably going to cause pain and poor technical ability, but not dystonia.
Thanks. I had a patient guitarist who had this focal dystonia. He did well after thalamotomy, the wide awake surgery. Yeah, he did well.
Yeah.
Do anxiety does anti-anxiety medication really work in these patients?
Which drugs?
Anti-anxiety, yeah, drugs.
Not per se. I mean, drug treatment doesn't work very well for this. Systemically, they've tried everything. Anticholinergics are sometimes given, but they have horrible side effects. Particularly for musicians, having a dry mouth or something is not going to work very good for you. Parkinson's type medication, there are some forms of this that are more aggressive, and you can give dopamine, it doesn't work very well. And then Botox. Botox is big in this. It's very, very patchy, but it sometimes works.
Thank you.
So one final question.
Can it happen even at rest? Even at rest? Is it always needs a stimulus for it to exaggerate, or can it happen even at rest?
It can affect, it tends to affect distal. It tends to affect fingers and thumb more than anything else. But you can get certainly you can get a massed forearm contracture, and it goes like this a little bit. There are difficult overlaps because some of the dystonia that we see is a bit more fixed, and they have this fixed posturing that may settle under GA, but otherwise it almost looks like spasticity. And as I said earlier, sometimes there's an interesting group that we all see a little bit, which is people with mild cognitive impairment who developed a clenched fist, often with sparing of the index and thumb, and and then they have a hygiene problem. And they don't need their hand so much, so you often do things, well, I just do flexotenotomies for them because it's very simple, it takes 2 minutes. And Botox and superficialis to profundus transfers and flexor to extensor transfers don't really work on that group very well. Thank you very much.
Thank you very much, Dr. Graham. So with that, we close our sessions, and thank you very much for your attendance.